Forgot about that part.
We have
All right.
cars at least.
Yeah, it's good.
So we can't talk about electrical impulses without talking about synapses. Okay, synapses. Remember, on Tuesday, I said that we have two types of synapses? One's electrical, one's chemical. Which one is most common in babies and small children? Electrical, good. So electrical synapses occur where cells joined by gap junctions allow an action potential to simply continue along postsynaptic plasma membrane. When you hear the word post, what do you think of?
After.
Yeah, after, good. So if we have a post, we're going to have a pre, you got it, okay. So right now, we're talking about the postsynaptic plasma membrane. Chemical synapses occur where presynaptic cells release chemical transmitters called neurotransmitters that cross a tiny gap to the postsynaptic cell, possibly inducing an action potential. Right? Why do I say possibly? Because sometimes it's not going to do anything. Right? Okay. So electrical synapses occur between cardiac muscle cells and between some types of smooth muscle cells. Electrical synapses are found throughout the nervous system in early development. These early electrical synapses are thought to be eventually replaced by the more complex chemical synapses. I want you to know that there are three structures that make up a chemical synapse. Three structures. There's a synaptic knob, a synaptic cleft, and the plasma membrane of the postsynaptic neuron. And I will test you on that. Okay, my nurses, so this is an excellent visual comparing electrical synapses to chemical synapses, okay? Without me saying anything, okay? Look at the first one, look at the electrical, okay? And then look at the chemical. Which one looks the least complicated? The electrical one, right? And that's because we have these tight junctions here, and then we have these gap junctions, and all we're talking about, this is the presynaptic, this is the post, and all we're talking about is these electrical charges moving into the postsynaptic cell. That's all it is. You know, we're not relying on chemicals or anything, it's just purely electrical charges. That's why I said with infants and small children, it's almost entirely electrical impulses for them. And then as they get older and the brain develops more, now we're going to have the chemical synapses. So let's look at a chemical synapse. First thing you want to look at is the presynaptic. Okay, before the presynaptic. Down here we have the post. So let's see what happens in the presynaptic neuron. First thing you want to think of is mitochondria, because we have to have ATP for any of this to happen. So lots of mitochondria, lots of ATP. Second, we're going to have these synaptic vesicles. And I don't know, in my mind, I like to visualize these as little cars. Okay? So they're little cars, and they're going to carry the neurotransmitter. Okay? And that's the chemical, the neurotransmitter. This all takes place with the synaptic vesicles and the neurotransmitters. It all takes place in the synaptic knob. Okay, so the neurotransmitters are going to catch a ride in the synaptic vesicles. These synaptic vesicles are going to carry the neurotransmitters to the end of the synaptic knob and release them into that synaptic cleft. Okay? What did I say determines whether a neurotransmitter is inhibitory or excitatory? Starts with an R. The receptors. So look what's waiting for them. The neurotransmitters are released from the synaptic cleft, and now you got all these receptor molecules just waiting to receive these neurotransmitters. So this one, let's look at this one here. This one could be excitatory. So that means that that neurotransmitter is going to be excitatory. If we're talking about the autonomic nervous system, and we're talking about parasympathetic, what do we want that neurotransmitter to be? Excitatory or inhibitory? Referring to digestion. Remember, for the parasympathetic, it's rest, repair, digest. So if this neurotransmitter, let's say it's acetylcholine, do we want that receptor to be excitatory or inhibitory? Excitatory. Now, let's look at this one. Now we're talking about the sympathetic nervous system, and we're talking about digestion. Do we want it to be inhibitory or excitatory? Inhibitory. So you see how the neurotransmitter never changes. It's the receptor it binds to that makes the change. Okay? So keep that in mind. I'm going to talk more about this in a minute. But you see the difference of the two. So electrical synapses involve gap junctions that allow action potentials to move from cell to cell directly by allowing electrical currents to flow between cells. And that's what we're doing here. Chemical synapses involve transmitter chemicals, neurotransmitters, that signal the postsynaptic cells to possibly induce an action potential. And again, that's what we see here. In a minute, we're going to talk about the three things that happens to these neurotransmitters. Okay, so we'll talk about that in a minute. The structure of a chemical synapse, so we have the synaptic knob, we have the synaptic cleft. A synaptic knob is a tiny bulge at the end of the terminal branch of a presynaptic neuron's axon that contains vesicles housing neurotransmitters. A synaptic cleft is the space between the synaptic knob and the plasma membrane of a postsynaptic neuron. So an action potential reaches a synaptic knob, and in this case, they're talking about calcium ions, causing calcium ions to diffuse into the knob rapidly. Neurotransmitter molecules diffuse across the synaptic cleft and bind to receptor molecules, causing ion channels to open. Okay. So slide 37, I really want you to know, so you want to highlight this. Opening of an ion channel produces a postsynaptic potential. Post, you told me, is what? After. So during the postsynaptic, we're going to see whether it's inhibitory or excitatory. Postsynaptic potential and postsynaptic potential. Okay, so we're going to see whether the neurotransmitter will be excitatory or inhibitory. The neurotransmitter's action is quickly terminated because the neurotransmitter molecules will do one and or three different things. So, number one, transported back into the synaptic knob, which is referred to as reuptake. Okay, so let me show you, let me go back to the picture for a minute so you can get the image. So here's the neurotransmitters, right? We just said one thing that can happen is that it's called reuptake, and it goes back into the synaptic knob. Okay, reuptake. We'll talk a little bit more about that in a minute. Or they can be metabolized into inactive compounds by enzymes. Okay, that's the second thing that could happen to these neurotransmitters. Or they could be diffused and taken up by nearby glia cells. Okay, they're the three things that can happen to these neurotransmitters. So if potassium channels open, potassium rushes outward. If chloride channels open, chloride rushes inward. Doesn't matter really what ions we're talking about. Either event makes the inside of the membrane even more negative than at the resting potential. So the glia cells may release them again for reuptake by the presynaptic neuron, sometimes after breaking them down into another form. So they may be different than when they first appeared. So on 39, let's look, this is similar to what we looked at, right, with a chemical synapse, but a little bit, it's adding a little bit more information. So let's start again with the presynaptic cell. We got the mitochondria, we got all this ATP, right? We've got the neurotransmitters in the vesicles. The vesicles are going to transport those neurotransmitters into the synaptic cleft. So remember, what's the one thing that can happen to those neurotransmitters? It's called reuptake. It's going to be, these neurotransmitters will go back into the synaptic cleft. Into the ball, the synaptic, let me get that knob. I couldn't get the knob. Into the synaptic knob. Okay, that's the first thing. So it says reuptake. So after synaptic transmission, the signal must be stopped by removing neurotransmitters from the synaptic cleft. Many neurotransmitters are immediately transported back into the presynaptic neuron in a process called reuptake. Some neurotransmitters are broken down by enzymes in the synaptic cleft, and the resulting molecules are transported back into the presynaptic neuron for recycling. And some of the neurotransmitter molecules may diffuse out of the synapse and be transported into a nearby glial cell, which may return as an altered form of the molecule to the presynaptic neuron. And see, that's what we see here. So here's your glia cells. Now, going back to the first one, where have you heard the word reuptake before? Regarding what? You got it. Okay. So, in order to understand this, let's pretend that the neurotransmitter that we're talking about right now is serotonin. Right? Serotonin you want to think of as a feel-good neurotransmitter. Makes you feel really good, right? Okay. Someone that is suffering from clinical depression, that serotonin, when it's released into the synaptic cleft, it is immediately sucked back up. I mean immediately, I mean as quick as it gets in there, it goes right back up into the synaptic knot. So that's why, if anyone tells you that clinical depression is not a thing, it's a thing. Because it is a chemical imbalance of the brain. And so that's why, you know, we have these drugs like Prozac, which is a serotonin reuptake inhibitor. So it allows that serotonin to stay here longer so that the patient feels good. Right? Now, if you don't have this chemical imbalance, everything's going to be fine. You know, the serotonin comes in, you know, it's all, you know, you just don't want to confuse depression with clinical depression. There's a huge difference. We all get depressed. Yeah, I get depressed when my Cowboys lose. But it's not a real, you know.
So it's every week.
Yes.
So it's every week, yeah.
What's the difference between like an SSRI and the other ones, like either serotonin inhibitors?
So the other ones work kind of the same way, right? It's going to deal with the chemical imbalance, but not focused on the serotonin. You know, we have other neurotransmitters that are feel good, dopamine's a norepinephrine, right? Yeah. I think I told you last semester when we were talking about experiments, and I did I synthesized Prozac in the lab. And, you know, one of the negative things about Prozac is that it makes you gain weight. I never thought that it would make the fish gain weight. I didn't think it would have anything to do with that. But my beta fish, they literally blew up. I mean, they looked like blowfish, and then they exploded.
Like,
They burst.
insane.
I know. And I felt so bad. To this day, I have a beta fish, and I feel so bad. So cute. But now we have antidepressants, like Wellbutrin, that can actually help you lose weight. Right? So it not only helps with depression, but it can help you lose weight. And that was the kind of the negative thing about Prozac. People felt good. They were like, yeah, you know, I feel better. But then they were gaining weight, then they got depressed because they gained weight. So it's kind of, you know, it's that imbalance.
There are studies out that a lot of, majority of nurses are either on depressants or alcoholics.
Oh, yes. Yeah, it's super, super high.
Yeah.
It is. It's super, well, the medical profession in general. That's why I tell my nurses, you have got to find a way to, you know, I call it being in the zone. So when you're at the hospital and you're working, you
Every
gotta
doctor
get in
has
that
told me
zone.
that I work with.
Right? And then when you leave, you gotta find a way to leave it there, you know? If you lose a patient, you know, I always say, if you lose a patient and it doesn't bother you at all, then, you know, probably the healthcare profession is not for you. Because that means you don't care at all, and you gotta care, you know? But you have to have a normal, you can't let it get to you, because you can get burned out really quick, you know? You gotta have a good, you know, try to have an outlet, right? You pick up, but when you're doing it, some of you already work in a hospital, so you know, it's really tough. And COVID, if that didn't, I mean, that was, yeah, it made it compounded it like 1,000 times.
Well, one thing COVID did do is got rid of a lot of crappy nurses and lazy nurses.
Mm. We have travelers now that are just shit, so.
There's that.
No. No, you need your 2 years of experience
But
and then
you know
you'll
what,
be.
you know, nurses work super hard. You know, I mean, usually, I mean, it's a tough job. I mean, it really is. But at the end of the day, think about, you're making a difference in people's lives, and I hope that that's why you're all here. you know, because you're gonna be the one that the patients remember. You're gonna be the one that the families of the patient remembers. It's not the doctors. It's gonna be you. So that's the positive. Synapses and memory. Synapses and memory. I'm gonna go into a little more detail about this later, but if you know of anyone that has had Alzheimer's or has Alzheimer's, as the disease progresses, you will see that they lose their short-term memory before their long-term. So they could be well into the advanced stages of Alzheimer's, but they could still remember their first address or their very first telephone number. But they can't tell you what you said 10 seconds ago, right? That's because with our long-term memories, we actually have a structural change in the brain that occurs. And that's what allows us to remember things when we were 3 or 4 years old, because there's a structural change. With short-term memories, there isn't. And that's why they have such a hard time with short-term memories. And that's what I say here. So long-term memories, months or years, require structural changes at the synapse. The other thing I want to mention, if you have patients that have dementia and you think that they're not there, don't talk about them. Because, you know, we know that they have moments where they understand, right? And can you imagine how terrifying that is if they hear you say, yeah, you know, pretty soon they'll be dead, you know, they're gonna die soon because they're having trouble swallowing or whatever. Can you imagine though how scary that would be? So, you know, you always want to treat them as if they know exactly what you're saying. Right? I had an Alzheimer's patient that I was treating, and I went to her house, and the only word she ever said for the 6 years I was treating her was Jim, and that was her husband's name. And so everybody just thought, well, she has no clue of what's going on. And one day her son came in and he had real long hair. And I had her sitting on the side of the bed and she looked up at him and she said, you need a haircut. Hmm? So there was something there, right? I mean, even if it was fleeting. So that's why I say don't, you know. Okay, neurotransmitters, means by which neurons communicate with each other. So there are more than 50 compounds that are known to be neurotransmitters. Do you have to know all 50? You only have to know a select few. Okay, dozens of others are suspected. The function of neurotransmitters is determined by the postsynaptic receptor. You see, you already know this. Right? You've already got that down, right? You do, I trust that you do. Chemical structure, the mechanism by which neurotransmitters cause a change. Chemical structure, the mechanism by which neurotransmitters cause a change. I want you to know that there are 4 main classes of neurotransmitters. We have acetylcholine, we have amines, amino acids, and neuropeptides. Okay, so there's 4 main classes. You want to highlight that in your notes, circle it. The 2 major functional classifications are excitatory neurotransmitters and inhibitory neurotransmitters. You already know that. Because the functions of specific neurotransmitters vary by location, they are usually classified to chemical structure. So I want you to know that amines are found in various regions of the brain. They affect learning, emotions, motor control, and so on. Now, if I ask you what dopamine is, hopefully you're gonna tell me that it's an amine, because it's in the name, right? So that's easy, right? Dopamine is an amine, okay? It's found in some, mood pathways. When we talk about Parkinson's, we're gonna talk about how, sometimes their first symptom is severe depression. Sometimes that's what makes them go to the doctor, is that they're suffering from severe depression. And what happens in Parkinson's is that dopamine is compromised, okay? And if it's a feel-good neurotransmitter, and we don't have enough of it, the patient's going to be depressed. So Parkinson's, you wanna think of not just the pill-rolling tremors, but depression as well. Dopamine also has an inhibitory effect on certain somatic motor pathways. Well, this makes sense. What did I tell you to remember about somatic? It is always skeletal muscle. So what happens in Parkinson's? Well, they have the shaking, but then what else as the disease progresses? They can't walk like this. How do they walk? They shuffle like this, along with that pill rolling tremor. Epinephrine and norepinephrine, they're like serotonin and dopamine. They are involved in mood. They make you feel good. Okay, so you want to know this. Epinephrine, norepinephrine, serotonin, dopamine, they're all involved in mood, so you want to put that in your notes. They are also involved in motor control, specifically in the sympathetic pathways of the autonomic nervous system. Amino acids believed to be among the most common neurotransmitters of the central nervous system. Peripheral nervous system, amino acids are stored in the synaptic vesicles and used as neurotransmitters. Okay, let's talk about some disorders of nerve conduction. So because myelin is necessary for efficient solitary conduction in many nerve pathways, many diverse dysfunctions of the body may result. And of course, one of them is, we talked about it, MS, multiple sclerosis. And then we can have cerebrovascular accidents, CVAs, or strokes. Yeah, TIAs is a big one, so, or a small one, but
It's a small one.
Yeah, it's a small one, but common. So transient ischemic attacks, TIAs, or mini strokes. Reduction of blood flow from blockage or leakage can reduce glucose and oxygen delivery and can damage nerve fibers. How do we treat if somebody has these mini strokes? We give them what? Blood thinners. Blood thinners. Myasthenia gravis is an autoimmune disorder in which antibodies bind to acetylcholine receptors at the neuromuscular junction of skeletal muscles. In your notes, you want to put myasthenia gravis equals antibodies that bind to the acetylcholine receptors. You always want to associate myasthenia gravis with acetylcholine. Okay, I promise you, I swear, when you take the NCLEX, that's going to be a question. I have no doubt. You have to know this. Myasthenia gravis is where antibodies bind to the acetylcholine receptors. And I'm gonna go ahead and give you some more information that's not on here, okay, because I want you to know it. It involves the head, or the face and the neck. The face and the neck. It causes the patient to have ptosis, and that's P-T-O-S-I-S, ptosis, P-T-O-S-I-S, the P silent, so it's ptosis. What is ptosis? Eye drooping, so they're gonna look like something like this. Okay. As the disease progresses, it's going to affect their ability to swallow. So as a nurse, and if I have myasthenia gravis, what are you going to not feed me? Yeah, you don't wanna give me a steak, right? Cause that's your dad. But, you're gonna feed me soft food, okay? Soft food like clam chowder or, I don't know, soft, anything, mashed potatoes, things like that. Okay. Eating disorders with a wide range of symptoms like autism spectrum may involve synaptic malfunctions, and that's what we see all the time. You know, we're learning so much about autism. If you're interested, there's a documentary, and I think it's on Amazon Prime, and it's called Spectrum. I think it's called Spectrum. It's outstanding, and it talks about how, you know, of course, the earlier we diagnose autism, the better the prognosis. And they're using all these sensory techniques now to help with autism. It's a wonderful documentary, because unless you have autism, or you know someone that has autism that's close to you, I don't think people really understand it. I really don't. So it's an excellent documentary. ASD, also called autism, is a group of neurological disorders characterized by various combinations and severities of difficulty in social interaction, verbal and nonverbal communication, and repetitive behaviors. They actually have colleges now for autistic people, which I think is great. Okay. Any questions at all?
Why is autism harder to diagnose in females versus like in males?
I didn't know it was.
It's usually undiagnosed in females until they get to like almost their late
The
20s.
only thing I can think of is that females tend to have a better way of, I don't know. Covering up a little. I don't, yes.
So would dyslexia be considered like a neurological
Because I said yes,
too? Okay, I was.
but not to the level that,
Right.
that this is, obviously. One of the ways that you can, I always tell my patients, so, when your child is starting to walk and they walk on their toes, that's a big sign that they have autism. So you look for little things like that, you know, the eye contact, but one of the big ones that sometimes goes unnoticed is when they walk on their toes. So, I'm not sure about the male and female though. I mean, in my practice, I've had equal. I mean, I've had, and they were all diagnosed at a very young age, you know, as these topics.
How come they got rid of the Asperger's? The autism?
That's a great question. And there's a lot of psychiatrists and psychologists out there that are wondering the same thing.
I was curious if you knew.
Have you ever read or seen the DSM Bible for disorders? Have you never seen it? No.
Supposedly it's massive.
Yeah, it's pretty big, yeah, it's pretty big, and they add and take away all the time.
The thing that I see 9 to 10.
Let's call it something else.
But you know, if you get a chance to get a hold of one, look up some of the disorders and see how they overlap each other. It's very, very hard. That's why so many neurological disorders, they go undiagnosed, or psychological disorders, because they overlap so much. It can take years to get a proper diagnosis. Any questions for me? No? Okay. You got this all down, right? We can have tests now, you get it?